Well, I thought that was going to be the final one, but right then is when the storm just came through Shawnee and shut down our power. So of course I got lucky and saved what I had done up to that point. So we're just going to continue on from where I left off, but now we're going to deal with the final. This is our final recording. So anyways, pick up where I left off with the talking about jaundice. My son had an extreme case of that, and it was right at Halloween time. So my wife put him in 3 days before is when he was born. He had extreme jaundice, and she put him in a little orange onesie that looked like a pumpkin, but it appeared we had painted up his face because he was so orange. He fit right in with that little orange onesie. So anyway, everything's fine. It just takes the liver a little while to be able to start breaking everything down and all of that. And that's why sometimes people will be kept under those lights to help break that down and help the liver start to stimulate these things and that whole process. But we said transport is essential. Start on IV fluids if they show significant clinical jaundice. Communicate with medical control. Oh, here we go. Maybe. There we go. Thermoregulation, temperature. So average normal temperature of newborns is about 99.5 degrees Fahrenheit. The range for neonate is going to be about 97.9 to 99. The production of heat by metabolism, so we're talking about the non-shivering thermogenesis, so the creation of heat in a non-shivering way is the newborn's primary source of heat production. So that brown fat is unique to newborns. It's deposited in the fetus after 28 weeks of gestation. And this is all stored around the scapula, the kidneys, adrenal glands, neck, axilla. It's all used for that heat production. So heat loss occurs when heat is lost to the environment, just like we've all learned in EMT basic and through science classes. Fever, rectal temp greater than 38 degrees Celsius or 100.4 Fahrenheit. So oral temp typically is lower than a rectal temp on average, and axillary temp is lower than the rectal temp on average. So when you work in the ER, or maybe you might do it in a critical care setting, you have to get a legitimate temperature. You're probably going to have to do it with the rectal. So that's where you're going to get the most accurate temperature. So a newborn may not always present with fever in an illness or infection because of the immaturity of its temperature regulation system. So, it may not work the same way that would normally work with an adult. So they can become hypothermic or even hypoglycemic instead. So neonates who appear well but present with a fever, they carry an approximately 7% chance of having a serious underlying bacterial infection. So this fever, they can be caused by overheating or dehydration. So they have the limited ability to control their temp, so they do not sweat when they're hot. They don't shiver to raise their temperature. So the core temp may drop in newborns with serious life-threatening infection, giving them a higher risk of hypoglycemia, metabolic acidosis. Now, signs and symptoms include irritability, somnolence, decreased feeding, warm to touch. So when you're looking at them, we're going to examine for rashes, especially for petechiae or a pinpoint pink or like some red skin lesions like you see. Get a careful history about their activity, their feeding, their going to the bathroom, all of that. Look for any increased respiratory rate or work of breathing, because we talked about they could have some metabolic, some acidosis type issues and all of that. So, we want to see if they're trying to compensate. Obtain vital signs and ensure adequate oxygenation and ventilation. It all goes back to a lot of what we've talked about, right? Our ABCs and those life-threatening illnesses. So antipyretics, they are very controversial in the field for these little ones. Don't give them ibuprofen. So to cool, remove the additional layers of clothing and then improve ventilation in the environment. Hypothermia, drop in body temp to less than 35 degrees Celsius or 95 degrees Fahrenheit. So this is more common, as you can imagine, during the winter months. Moderate hypothermia linked with an increased risk of death in low birth weight newborns. So newborns have increased surface area to volume ratio, and they're a lot more sensitive to environmental conditions. So especially whenever they are wet right after their delivery. So metabolic function increase to overcome heat loss, that can cause a few different things, and we've talked about it a little bit. Hypoglycemia, metabolic acidosis, pulmonary hypertension, hypoxemia as well. Now in these, we need to look and investigate for infection to make sure that they don't, or hopefully if they do, we can find a source of infection. So they can be cool to the touch, initially in the extremities, and then pale with some acrocyanosis. So cyanosis kind of other extremities, away from the core. So they can present a few different ways: decreased respiratory effort, apnea, bradycardia, cyanosis, irritability, weak cry, lethargy. Preventative measures, so much like we've talked about with keeping all these guys warm and when we're having babies in the back and all that stuff. So warm your hands before touching the newborn, if that would help a little bit. Drying thoroughly after birth, make sure they're nice and dry, and you put a nice little cap on their top. Get them skin to skin with mom. Keep them covered once they're on skin to skin with mom. So treatment, hypothermia. If the newborn is hypoglycemic, you can administer some D10. Warm IV fluids can assist in rewarming the newborn. These are things I would probably, nearly all treatments that I would do to these little guys, I'm probably going to take a partner on, to be honest with you. I'm probably going to call my doc, just to make sure everything's good to go. Now, that doesn't mean that you need to. I'm just telling you my struggles. So once stabilized, it is ideal, if possible, to place the critically ill newborn in a pre-warmed incubator. Most of us aren't going to have that on the truck. So that's why we go skin to skin with mom and then cover up and keep the little hat on and all that stuff. But if not available, we're going to cover that newborn with warm blankets and place him or her on mom's chest, like I said. So ensure the ambulance heat is turned up, and then even consider some heat packs. But don't ever place them directly on baby's skin. Common birth injuries. Most of them are self-limiting, have a pretty favorable outcome, but newborn injuries can occur because of their size or their position during labor and delivery. So some conditions associated with a difficult birth. So primigravida, prolonged labor, cephalopelvic disproportion, prolonged or rapid labor, abnormal presentation, large size, shoulder dystocia. Most of these things we talked about a little bit. So birth trauma injuries include those that can involve instruments used during delivery, so abrasions, lacerations, bruises, those kind of things, if instruments are being used. So excessive molding of the head and overriding the parietal bones. So the head's a little too big, or it's just being pressed against a small opening, and it's causing some weird looking stuff here. Cephalohematoma, an area of bleeding between the parietal bone and the covering periosteum. So that can take a couple of weeks to resolve. Linear skull fractures, baby. So brachial plexus injuries typically occur in deliveries complicated by shoulder dystocia. Facial nerve palsy, so findings include asymmetric faces when crying. Now, full resolution of the cranial nerves, that can take up to several weeks because of this. Diaphragmatic paralysis, and that can occur from cervical root injury or a brachial plexus injury. So that newborn, they can experience several different things. Respiratory distress with hypoxemia, hypercapnia, acidosis. Laryngeal nerve injury resulting from intrauterine posture. So that can present with some stridor or even a hoarse cry. Paralysis often resolves in 4 to 6 weeks, and then even a spinal cord injury. So if they have had excessive traction or even rotation or torsion on them, that can cause some of that. Clavicle, most frequently fractured bone. That's in everybody, as adults, children, everybody. The clavicle is the most frequently fractured bone, most often unpredictable and unavoidable complication. So they do have some risk factors, large size, shoulder dystocia, mid-forceps, which we're not going to do, but mid-forceps delivery. Examination will show crepitus, maybe a palpable bony irregularity, possible lack of arm movement on that affected side. Even some long bone fractures can present as a loss of spontaneous arm or leg movement. Intra-abdominal injury is uncommon in newborns, but we need to consider in every newborn presenting with a few different things: shock or unexplained pallor, as well as abdominal distension. And then hypoxia and shock, it could be caused by birth trauma itself. Congenital heart disease, you've got them listed out here. You see, so you've got ASD, so atrial septal defect and ventricular septal defect, PDA, patent ductus arteriosus, a lot of different stuff here. You can see what it's causing, what it does. Most common birth defect occurring in 8 per 1,000 live births. So we're talking about these congenital heart problems. Approximately 1/4 are critical, so the majority are not. The leading cause of death among children with congenital malformations, and these can present with varying degrees of cardiorespiratory compromise. And all of that depends upon the particular cardiac lesion, so in these neonates and the infants. So they typically present in the neonatal period with increasing respiratory distress, poor perfusion, cyanosis, maybe even cardiovascular collapse. So really the big thing is going to be early recognition and then stabilizing them if they need stabilized, and make sure we get them to the right place. Non-cyanotic disease, so some pink defects. Oxygenated blood is shunted from the left side of the heart to the right side, and that's called a left to right shunt. Those are things that are important to remember. We'll talk about each one of these. Atrial septal defect. So allow some of the oxygenated blood from the left atrium to flow through the hole to the right atrium. What happens is you get this failure of that foramen ovale, if you remember. It's a failure of that to close after birth, and that's what allows this to happen. So you get an increased volume of blood flowing to the right atrium and ventricle, which causes chamber enlargement, as you can imagine. And then if the defect is not repaired, pulmonary hypertension usually develops in adulthood. Now, in infants and children, they're usually asymptomatic. They will present typically with a characteristic murmur, and they are at risk, these patients are at risk for atrial dysrhythmias. So move on to ventricular septal defects. What this does, it allows some of the oxygenated blood to flow from the left ventricle through the hole to the right ventricle and the pulmonary artery. So by doing that, cardiac output is affected, stroke volumes reduced, and then right atrium and ventricular can enlarge because of the pressures, and that will lead to pulmonary hypertension also. So in small openings now, these patients are usually asymptomatic, and growth and development are typically unaffected. But in moderate to large size opening, patients can often experience delayed growth and development, decreased exercise tolerance, repeated pulmonary infections. So infants and children with a ventricular septal defect are at risk for bacterial endocarditis. And then moderate and large defects, they may require surgical closure of this. Now, PDA, patent ductus arteriosus, that exists when the ductus arteriosus fails to close after birth. So we see this up here. Persistence of the ductus arteriosus beyond 10 days of life is considered abnormal. Now, what happens, you get oxygenated blood traveling through the aorta. It's shunted from the aorta across the duct to the pulmonary artery, where it mixes with deoxygenated blood. So that workload of that left atrium and ventricles increased because of the additional recirculated blood. Now, because of that, less blood is delivered to the lungs. And you get a lot of different things. Symptoms depend on the size of the ductus and how much blood flow it carries. So signs and symptoms associated with a large shunt, they can include a lot of different things: fatigue, failure to thrive, poor feeding, abounding peripheral pulse, that characteristic murmur, increased work of breathing. But Here's the downside. If left untreated, it can cause the patient to subsequently develop heart failure. So these are things that really, nearly all of these really need to be taken care of. So a COA, coarctation of the aorta. It's that narrowing of the aorta. So basically it's a pinched or constricted in that area of the ductus arteriosus. Because of that, increased blood pressure proximal to the defect and decreased blood flow distal because of that constriction or pinching. So it can be associated with other cardiac defects, typically those involving the left side of the heart. Now, they are asymptomatic in most patients until later in childhood, but you get dyspnea, poor feeding, poor weight gain, high blood pressure, bounding pulses in the arms, lower blood pressure, chest pain, muscle weakness, a lot of different stuff. Cyanotic disease. So deoxygenated blood from the right side of the heart mixes with the left side, and that's where we talked about a second ago. We have that right to left shunt. Pulmonary stenosis, pulmonic valve near the right ventricle, it becomes damaged. So the patient will have a decrease in blood flow to the lungs and will present with a few different things: JVD, cyanosis, right ventricular hypertrophy. And this is typically associated with CHD, but can also result from rheumatic heart disease. So typically associated with, when we say CHD, congenital heart disease. Truncus arteriosus, pulmonary and aorta arteries are combined as one vessel, which, as you can imagine, can become a problem. Greatly increases the blood flow to the lungs, causing CHF, and this guy is going to require surgical intervention. Tricuspid atresia, a lot of different things. I know, just pay attention to these and get a general understanding, be able to pick one out from the others. Tricuspid atresia, tricuspid valve is missing, so that results in an undersized or absent right ventricle, have a significantly decreased blood flow to the lungs, leading severe hypoxemia and death. And this can require procedure to direct the inferior vena cava and the hepatic vein into the pulmonary circulation. Hypoplastic left heart syndrome. The left side of the heart is completely underdeveloped, and as you can think how important the left side of the heart is, so it's unable to fulfill its circulation needs. It presents with a murmur or cyanosis, and if this can require a heart transplant if a surgical intervention cannot be performed. Tetralogy of Fallot. So what we're talking about here is a combination of 4 different defects. VSD, pulmonary stenosis, right ventricular hypertrophy, overriding aorta. Now, most of these infants are pink at birth because they usually have a patent ductus arteriosus or a PDA that provides additional pulmonary blood flow. But as the ductus closes in the first hours or days of life, cyanosis may develop or even become more severe. So you can get some clubbing that goes on. Blood flow to the lungs is reduced, characteristic murmur. When arterial O2 sat suddenly decreases, an infant or child may experience a tetralogy spell. So also called TET spells, which we're talking about hypoxic spells, or hypercyanotic spells, blue spells. They usually result from sudden increased constriction of the outflow tract to the lungs. And what happens is these kids become increasingly cyanotic and irritable, breathes quite deeply and rapidly. And if left untreated, you can see things like syncope, seizures, stroke, or even death. Often this will occur in the morning after crying or feeding or even a bowel movement in infants. So management, keep the infant or child as calm as possible. Infants should be picked up and held in a knee to chest position. Often older children often squat to recover. So we want to give O2, get some fluids if needed, medications as ordered by your doc. Morphine can be ordered to suppress the respiratory center and resolve the hyperpnea, and this requires open heart surgery. So tetralogy of Fallot is a really big deal. And one of our last ones, we only got a couple left, so stick with me here, guys. Transposition of the great arteries, TGA, positions of the pulmonary artery and the aorta are reversed. So blood goes to the lungs for oxygenation, then returns to the lungs, while blood from the body to the heart goes back to the body without becoming oxygenated. So as you can imagine, cyanosis is usually present. They can have some clubbing as well as shortness of breath. This is going to require surgical intervention. Total anomalous pulmonary venous return. 4 pulmonary veins connect to the right atrium instead of the left atrium. So that results in a diminished O2 and increased load on the right ventricle, and they'll usually present with signs and symptoms shortly after birth. Rapid detection and transport are mandatory on these. So the whole idea is that we detect these. Obviously, these are not things we're going to be able to do anything about, and atropine doesn't fix any of them, so we're kind of limited. So rapid detection, just like many of these, we'll call this like a time-sensitive matter. So strokes and MIs and all of those where recognition is really one of the most important things, same here. So communication with medical control is critical to have adequate services available upon the arrival at the emergency facility. So as you can imagine, one of your most important decisions here is going to be to get to the right facility. So if you got one of these kids that are getting sick, it's going to be really important to get the children's versus, Prague Hospital or something like that. Now, you still have to follow your local protocols, but if your protocol states that you can't go anywhere other than wherever, this is a time that you need to probably call a helicopter anyways. So, look at that. There we are. You didn't think we were going to make it, but we did. So, that's it. Part 4, or part 3.1. of Chapter 42, Neonate.